Hello?
Hello? Hello?
Yeah, Wayne?
Yeah.
We're all trying to get here.
Kind of like we're trying to land somebody on the moon.
I think you probably could do that easier. Some are on the phone, some are on the computer. Hi, Carl.
Hey, Stephanie's on here. There's Carl. Hey, Carl. Carl, is your audio working? Nope.
Nope.
I can't hear you.
No audio.
Carl, I think I hear you, Carl.
Can you hear me now?
Yeah.
Well, I guess I gotta have my dead gum camera right up to my mouth or something.
Well, I will tell you there, and I can send it. There's a call-in number that you can use as well. Like that's what I have to do because I don't have a microphone or a camera on my computer. So what I have to do is use the call-in number, and that's how y'all can hear me.
Okay, well, I'll probably use it too.
Well, we can hear you.
Did you hear that?
Hear what?
I hate technology. It never works.
Stephanie?
Yes, Robin?
Okay, how do I mute what I'm seeing on the computer?
How do you mute it? Or how do you get the video?
I'm seeing the video, but I'm hearing everybody on the phone and on the computer.
Well, that's because there's a lot of people that's not muted. It should get better.
No, I mean, I'm hearing it double.
So you called in on your phone and you're hearing it through the computer?
Right.
Well, you can either turn your speakers on your computer off, or you can actually even hang up your phone and just use, like Carl and everybody else is just using their microphone off of their computer.
Okay.
Scott, can you hear?
I can hear. Can y'all hear me?
Can. How are you feeling?
I'm fine. I think Brandy's a lot better. So hopefully she'll get released in the next day or two.
Would be good.
What happened to Brandy?
She got tested positive for COVID.
Did not know that.
Yep. So we've all been quarantined for about a week now.
Well,
She never really got real sick. She lost her energy, lost her taste, lost smell. Ran a low-grade fever just for a little bit, but she seems normal now.
well, that's great. Fox report, I think it was this morning or maybe yesterday, about how many different testing applications have been distributed, FDA approved, like hundreds of them or something. And apparently a lot of them have a real high level of false negative. There's been a false negative.
That's part of the issue, yeah. I think the machine that we're getting is the most accurate on the market, according to our lab people.
Good.
It looks like Jay Jones is still working on getting on the call.
Stephanie, as far as you know, is Josh and who else we looking for? Josh, Jay, and Reggie.
And who?
Reggie.
Let me see. I just text.
This is Josh. I made it on.
Was that Josh?
It's me.
Hi, Jonas.
I'd like to remind everybody to mute their computer if you're not talking. Okay, let me see. I'm waiting on Jay. All right. Looks like Jay's trying to text me out. Okay, he's calling in right now.
Good morning. This is Jana. Can y'all hear me?
We can.
You can.
Oh, good. I got on the first time and I don't see anyone good, so I logged back out and logged back in. Seems to work.
Okay, this is Jay. I made it.
Hi, Jay.
Good morning, everybody.
Good morning.
I think that's everybody.
Do you know if he's not going to be here?
Reggie should be on the call. He told me he was.
Okay, well, you want to do a roll call?
Sure. All right, we got Mike.
Here.
Wayne.
Here.
Carl.
Here.
Reggie. Well, his text said that he was in and out, so he said I'll be in and out depending on Josh.
I'm here.
Robin.
Here.
Jay.
Here.
Okay. Judge. Okay. Scott.
Here.
Melody. She's on here. I just can't hear her. Let me find out what's going on with her. Jenny.
Here.
Okay.
Okay. Leah.
Here.
Rusty. Rusty's he's multitasking as well. Okay. Jody.
I'm here.
Okay. Seth.
I'm here.
All right. Savannah is on the call. And then media-wise, do we have anybody with the advance?
I'm here, Melissa.
Okay. And then Wesley, are you on here from, I can't remember, Southern, what is?
Yes, I'm here.
Okay. And then Joe, are you on here? All right. And if I have not called your name, if you're on the call, would you please state your name?
Reggie's here.
Okay.
Steph, can you hear me now?
Yep, I can hear you now.
Okay.
All right, Mike. Nobody else spoke up, so.
Okay, thank you.
Mhm.
We'll go ahead and call the meeting to order. We had contemplated trying to do this live, but decided that it was probably in the best interest of all concerned to go ahead and do another WebEx meeting. We'll see how things go. Possibly we can try to have a live meeting in the end of July. But technology seems to be working for the most part this morning, and we're all here, so we'll go ahead and get started. We got a lot of ground to cover today, so we'll try to move it along as quickly as possible. Presentations this morning, one from HRG and then another one from two from anesthesia groups. So Stephanie, are the presentations from anesthesia, YPS, and Sweet Dreams, are they going to be WebEx?
Yes.
Visual?
Yes.
Video? Okay.
Yep.
Okay. Well, Savannah, I heard you earlier, so I'll go over to you.
Thanks so much, Mike. All right, let me get my presentation on the screen here for everyone. Oh, well. Can everyone see my screen?
I can see it.
Yep, I can see it.
Perfect.
Yes,
All right.
I can see it.
All right. Well, my name's Savannah Ward. As you all probably know by now, I am the HRG director that oversees the relationship with Drew. So I'll jump in. Feel free to stop me at any point if you have any questions, or of course at the end I'll leave some time as well. So I wanted to look at revenue first. Usually I think we go over cash first, but just because obviously revenue has such a big impact, so I'm getting a lot of feedback. Okay. So revenue obviously has such a huge impact on the revenue cycle, how much cash we can collect, AR days, as well as aging percentages. We know that COVID has had a huge impact on revenue, not as much as other facilities that we've seen, but still substantial. So obviously we see the downward trend line here. Sorry, it's very echoey. Let me see if that's any better.
So if you're not talking, if you can mute your mic, that'd be helpful, I believe.
Thanks, Scott. So we see the downward trend line here. We know that's due to COVID, but we do see a rebound coming here in June. Revenue was already at $7.5 million as of the 25th, so that's where we're getting that projected June number. We had projected more of a rebound in May than we saw, and only ended up at $7.2 million. However, admissions were actually up 864 from April, and we're at about 88% of the 13-month average. So I'm curious, maybe there was some delay in charge entry that we didn't capture everything in May. I'm not sure. It was a lot lower than what we had anticipated based on the activity, but we are seeing that increase in June. So May was at about 87.5% of the 13-month average, and June's looking to be even higher. So for cash collections, in May, we ended up collecting more than we were anticipating at almost $2.5 million, or 125% of April's low revenue. So that was fantastic. And then in June, despite that overage last month, we're still anticipating hitting 100% at just under $2.2 million. So that brings the 6-month average cash collections to 116% of net revenue. So that's for May and back 6 months. Overall AR, obviously, we want to continue to see the total gross AR come down, and we have month over month since January. We see the downward trend of the dollars. However, since March, obviously the AR days have been slowly climbing, and that's a result of the reduced revenue. So the way that we calculate the AR days is the last 3 months worth of revenue divided by the number of days in that same time period, and that gives us essentially the value of an AR day. And so when we're dividing the total by a smaller number, we're going to get a larger number in return. So because the last 3 months have been impacted by COVID and revenue was lower, we saw the average daily revenue drop another 24,000 in May. So we saw the total AR days climb. We do anticipate with June rebounding, and hopefully July and August follow suit, we would expect that the average daily revenue is going to rebound probably in August, and then we'll see AR days stabilize and start going back in line with what's happening with the growth. But AR has been reduced 3.3 million, or 18.5%, since the high point in January where it was at 18 million. We did see a large drop from April to May at about $1 million, and that was more than we were anticipating. That was a combination of the increased cash that we saw and also the lesser revenue. So less AR was coming onto the books, and we also still saw that higher cash collection, so we had more resolution. Had $1 million between April and May. Unbilled did grow slightly, but third party and self-pay both went down. And then again, I talked about the AR day increase despite the reduction to gross AR and the reason for that. In third-party aging, last time I was here, we had talked about looking at it by the aging bucket so we can see, is it doing the slope that we want where we have most of it in the front and it slowly tapers off? That's really the trend line we want to see. And as you can see, the majority of the AR is in the 0 to 30, of course, followed by 31 to 60. So that's great. But then we jump back here to the over a year. Obviously, that's not what we want to see, but we can also tell that the majority of that is Medicare, and the large 90% of it's Medicare, and most of that is those opt-in behavioral health claims that we know are pending legal that Drew is still working on. So our focus is really this 181 to 365 bucket, and again, the Medicaid and commercial that make up that are what we're focused on. With third party, we did see an increase in May of 84,000, and that was the first time we had seen growth to the aged inventory since November. That backslide kind of had a lot of, excuse me, I have something in my throat, had a lot to do with an increase in denials. There was also an increase in communication logs. So we'll talk about some of the things that contributed to the growth to the aging that we saw in May in some of the subsequent slides. But that really shows us where our focus needs to be, and specifically that 181 to 365 bucket for Medicaid and commercial.
Lana.
Yes. Hello?
Everybody leave us?
Can you still hear me?
No. I can hear you, Savannah.
Okay, perfect. Did you have a question, Mike?
No, I did not.
Oh, I thought someone did. Okay. All right. So the communication logs, like I mentioned, did have a little bit of an impact on that growth to aging that we saw. The communication log has been trending much lower than it had been in the past through April. And then we did, unfortunately, see a spike in May. I did include the average communication log response time in May was 7 days, which is the same as what it was in March, and it was still down from December when BKD was on site and they were at 12 days. The goal is 2, but it's gone down since December. So we're still seeing progress there, but there was an increase to the outstanding comm logs, and a lot of that likely had to do with the increase in denials as well. You can see here the majority of them are modifiers followed by coding review and then authorizations, which was the top denial, and we'll look at the denials on the next slide, also had a large amount. Just to let you all know that we have seen a decrease in the outstanding communication logs since the end of May, and as of the 26th, they were at only 428,000, but of the total that were outstanding at the end of May, about 13.6% of the total aged inventory was on a communication log at the time that the month closed. Excuse me, it was 306,000, not 13.6%. So we do see that the communication log, obviously, if we receive a denial or it's held up on the front end for billing to the insurance and we have to put it on a communication log, that's delaying resolution. When BKD was on site, they identified that, of course, if we want to speed up reimbursement, there's a couple places that the account can get held up, one of them being unbilled, and the next one was the communication log. So just making sure that we keep this low will help us resolve the accounts quicker. So for the denials, like I mentioned, there was an increase in denials in May. The top denial reason was no authorization, followed by non-emergent urgent and other insurance prime. On the left-hand side here, we can see the denials by root cause were primarily registration. 2 out of the 3 of those top 3 denials were rooted to registration, so no authorization as well as the other insurance prime. So I think the authorizations is really a focus point, and I'll talk about in the updates and action items that we do have a strategic planning meeting coming up, and I think that's where we'll really dig into any issues we've identified that are holding up resolution or holding up cash, where we can dive in and kind of make some corrective action. And authorizations, I think, is a focus point on both sides. That'll be something I'm sure that we talk about. So, and I just wanted to note with the increase in denials, we still are only seeing about, so the actions taken on these denials, only 4% of these resulted in an adjustment. So while the increase in denials looks scary, I don't want it to be associated with necessarily lost cash. Of course, it delays resolution and delays the cash and then contributes to increased AR or increased aging. But we are still actively pursuing the majority of these dollars. Only 4% resulted in an adjustment. So with adjustments, we talked about this last time as well. I wanted to take a dive into some of the adjustment reasons and which ones are the bulk and why this also relates to your collection rate. Obviously, if we can reduce the number of write-offs, then that's going to increase your collection rate. So taking a look at the adjustments by reason as well as financial class, we can see that the majority of the write-offs that are happening are due to non-covered. Those are primarily commercial and Medicaid. When I looked at the commercial write-offs, those are mostly and better. So I'm not sure if that's a contract we need to look at, and we can get more detail, of course, again, in preparation for strategic planning surrounding what they are deeming as uncovered and why. But that was the majority of the commercial bucket. And then as we know, Medicaid processes a large majority of the drugs and supplies as non-covered per their fee schedule. Some of those revenue codes are not even on their fee schedule, and so they don't pay on them. We are having an issue with chemotherapy as well with Medicaid, and obviously that's a large dollar amount. So that contributes to the Medicaid aging as well. Medicare, we saw a large number of medical necessity write-offs. And those are mostly infusion, radiology, and labs. And when we have an account drop and there's a procedure that's been done that doesn't have a diagnosis that makes it medically necessary, we will add that to the communication log to verify that there's not a diagnosis to cover the service that was done. And then if there isn't, unfortunately, it results in a write-off. We don't see a lot of ABNs being signed for those Medicare beneficiaries. So in the instance that the physician determines that it may not be payable, if we can get those ABNs, we can bill the patient for those. So I think that's another item that we can talk about in the strategic planning to try to diminish some of those write-offs is how do we get the physicians to only provide services that are medically necessary, or in the instance that they feel it is necessary, even if maybe the diagnosis doesn't warrant it, that we're making sure that we're getting those ABNs so we can bill the patient if we let them know ahead of time, we don't think Medicare is going to cover this. So if you still want us to perform it, then you can sign this, and then if they don't pay it, we'll bill you directly. So I took another look at the self-pay. It's kind of the same as what we looked at last time. We wanted to take a look at if we include what we have, we assume the balance after insurance will be, because we know that Medicare revenue has increased substantially. So just looking at self-pay revenue maybe wasn't giving us the whole picture. So I took a look and I included the assumed balance after insurance from Medicare, commercial, and Blues, and it didn't change the increase. So we're still seeing a much larger increase in the write-off versus the revenue. That may also, though, not include things like Melody mentioned last time where they were adjusting potential self-pay balances within contractuals, or the Medicaid where it's deemed non-emergent. We can bill the patient for those, and we know that FDOA was billing all of the Medicaid as if they had a PCP referral. So there are some additional balances rolling into self-pay that still may not be included, but based on the data that we have, it looks like the increase to bad debt is still a lot larger than the increase to what's in self-pay revenue. And So I included the payment policy changes again, just because I do feel like that is primarily why the bad debt is so much higher than it was previously. We're really holding the line with patients as far as making sure they're on a payment plan that is reasonable based on their balance, that they're paying at least $50 a month and not making a $5, $10, $20 payment, and avoiding collections and keeping that AR on the books for a long period of time. And then we're also, if a patient is at 120 days and they still haven't gotten on a payment plan, even if they're making payments, they will be eligible for collections. And that's just to avoid patients making payments that they deem are enough versus getting on a payment plan within the guidelines. So instead of making a payment of $25 every month and avoiding collections, they are required to get on a payment plan that we approve that will pay off their balance in a reasonable time frame. So I really think holding the line is the reason that the bad debt write-offs are so much higher. And again, if we're concerned with the collection rate, that might be something to look at. I think tackling some of the adjustments that are avoidable first, rather than making these guidelines less strict, would be better. But obviously we can make this a little bit more lenient for patients if that's a route you want to go to reduce those write-offs. We just then run the risk of running higher self-pay AR over the period of time while we're waiting for those patients to meet the new guidelines. So it's something that we may want to discuss. I just wanted to show that the balance after insurance did not change that increase to self-pay revenue. So for updates and action items for collections, obviously, if we continue to reduce the unbilled and the communication logs, then we can get those shorter days to pay from insurance and thus resolve the accounts faster and get the money in the door quicker. Focusing on avoidable registration denials, specifically authorizations, because they usually impact high dollar claims, and then providing only medically necessary services and obtaining ABNs when those are appropriate. Those will all help get cash in the door quicker, as well as potentially improving the collection rate with those medically necessary services. For AR and aging cleanup, we still have Optum Behavioral Health out there. We know that Drew's working on coming to an agreement with Optum to resolve those balances, but it does make up the majority of what's aged over a year, increasing the aging balance and the total AR. HRG will continue to focus on the aged inventory, specifically that bubble we saw in the 181 to 365 range. And then, as I mentioned, we've planned strategic planning for the 15th of July. What that is we'll go, because we'll have been live for a whole year, which we're very excited about, we'll take the year's worth of data, go over it, see what we can fine tune, what we still need to work on, and select 3 or 4 main goals. And then we're trying to do this quarterly, so we can come back, we can use that action plan that we get after we all meet to touch base every week during our revenue cycle calls, as well as meeting back up in about 3 months and say, okay, here's what our 3 or 4 goals were. Did we meet those, or do we need to put those on the list again? And if we did meet them, what new metric do we want to add in that we want to focus on over the next quarter? So that's usually how those work, and what we would like to implement with Drew going forward. Because they're so collaborative, we're able to work together, and they're so responsive to any feedback that we give. And it's just been one of the clients that we think we can make a model client because it's such a collaborative effort. So with self-pay, the tax season discount is coming to an end in June. The total so far is about $22,000. So I don't know what it had been in previous years, but it seems like a low amount of participation, and likely due to COVID. We also are set to revert back to the stricter bad debt guidelines after June. So again, that may be something we want to touch base on before we do that. Currently, we're allowing patients to make any payment that they're able to avoid collections through this time, because we know they're impacted with their jobs and such. So after June, we will revert back to the old guidelines, unless that's something that Drew would like to change. Did y'all have any questions for me, or any slides you want me to go back to that we can talk about?
Savannah, this is Mike. Just one question. Back to what we discussed last month, contractuals were 69%. 73% year to date. We're being presented with a revised budget today that shows contractuals to be 66%. So my question is, by next month's meeting, we need to have a conversation about where do we think contractuals are going? Do we think we can get to 66%, which is really higher than what we had discussed? But just 2 months in to the fiscal year, it's $900,000 between 73% and 66%. So, I mean, if we don't think we can get to 66%, we just need to know, because we'll need to internally deal with that and make plans accordingly and probably revise the budget again. So that,
Right.
I think you're having the strategic planning the middle of July. So hopefully that's something that can be discussed. And then at next month's meeting, because we just need something real that we can deal with.
I think 66 is completely reasonable. And like I said, I think that the main things we can focus on, and we'll talk about in strategic planning that will impact that, is reducing write-offs with, non-covered, no authorizations, those kinds of things that are not non-covered, medically necessary and no authorizations. So if we can reduce write-offs that are avoidable, such as those, by focusing on those specific items, that will increase your collection rate. And again, if we do need to talk about bad debt and changing some of those guidelines, I don't know if we're robbing Peter to pay Paul. We want a better collection rate, but now we're running with higher AR. That's really a decision that you'll have to make. But I think 66% is doable if we focus on these specific avoidable write-offs.
Well, obviously, we'll have to have several months that are below 66% to get to that, given that we're at 73% year to date.
Right. Yes, and also with everything stabilizing, I think like I mentioned, with revenue coming back in June, and if it continues, I think August is going to give us the best picture of where we're at. We'll have 3 consistent months of revenue. Hopefully cash flow follows suit. AR days will be back in line, and we can really see where everything's sitting. Is it sitting in a status where we think we're going to get paid, or are there write-offs coming that are going to impact that collection rate? So we should have a good picture here in a few months.
Okay, well, hopefully by next month's meeting, we can, make some forecasts that we really feel comfortable with.
Yeah, and we'll be sure to, obviously, in next month's meeting, what we want to do is highlight, obviously, the year's worth of activity, and then we'll include the action items from the strategic planning so that y'all know what we're working on and then what we think those impacts will be.
Okay.
Savannah, can you hear me?
I can.
Yeah, this is Jay Jones. Question I had is, one question, how has this present environment impacted contractuals? Is it neutral to that, or are there ways that being where we are has negatively impacted our ability, or well, I say our ability, the level of contractual, how has that impacted where we are with contractions?
I don't think that on the payer side that it's had a big impact on those. I think in the lower revenue months, obviously we were focused on aging cleanup. So if there are any adjustments that maybe we were able to take quicker, that's going to show a negative to the collection rate because we're taking those additional adjustments that maybe weren't a result of what happened in the current month, but from cleanup from previous months. But of course, also strains within the hospital maybe might have led to increased denials, increased no authorizations, and things like that. So all of those additional write-offs can have a negative impact on the collection rate. But as far as the payers are concerned, I don't see an increase in contractuals for that reason because of the current environment.
Okay, thank you.
Sure.
Okay, any other questions for Savannah? Okay, thank you, Savannah, and we'll talk again
All
next.
right. Perfect. Thank you all for having me. I'll talk to you next month.
Okay, thanks. Okay,
Bye.
next up is the presentation from YPS. Are they where they can get online or on? They are online.
Stephanie, are you on?
She's trying to talk. Melody's out there trying to help her.
Stephanie's coming in my office. Here she is.
Hey, I don't have no idea what's going on. Anyway, YPS looks like they're not on just yet. They're supposed to be on by 10:45. And Sweet Dreams about 11:15. I did send YPS a message and told them that we were ready if they could sign on. But now I'm running back and forth between computers.
Well, Stephanie, if you get a response from them pretty quick.
Hey, Kobe, unmute Kobe. I just think. Hey, Kobe, can you unmute? Can you hear me? Kobe with YPS is on here.
Hey, how are y'all? Hi, this is Brian from YPS.
Okay.
Good.
Brian, we're kind of waiting on y'all. Whenever y'all get on here, y'all are up and ready to go.
Oh, very good. Looks like Tracy's going to be dialing in here shortly.
Can y'all hear me now?
Yes.
I just hung up and dialed back in, so I guess it froze or something.
Hi, Stephanie.
Yes.
This is Brian. I just got a text from both John Woodard and Tracy saying that it appears that they're not able to get in. Let me see what the issue is.
Hey, Stephanie, it's John Mendel.
Okay.
Good morning, everyone. Can you hear me?
Yes.
Hi, I'm Tracy Young with YPS Anesthesia. Sorry, my kept trying to log in for a while. It took a little while to get logged in. You ready to get started, or are we waiting on anyone else to join?
No, we're ready to go, Tracy.
Awesome. So, do you all have a copy of the presentation we sent earlier, or should I share my screen with everyone?
Please share the screen.
Okay, let's see here.
There you go.
All right, can everyone see that?
Yes, sir.
Well, good morning, everyone. Thanks. Sorry if there was a little bit of a delay with all of us logging on, and we definitely appreciate your time this morning. As I said a second ago, my name is Tracy Young. I'm the CEO and founder of YPS Anesthesia. And on the call with us, I believe we have actually a couple of more people than this presentation. We have Colby's on the phone. Colby is actually currently on vacation, but he wanted to log in as well. He's in Navarre Beach in Florida. We have Brian Young, our COO, and we have John Mendel, our CFO, and John Woodard, our business development coordinator as well. So Woodard's out of Dallas. The rest of us are all Louisiana based. Everybody want to say hi before we get started?
Hey, guys. Good morning.
Hey, good morning.
Good morning.
Good morning.
As I said just a moment ago, I founded YPS in 2003. And as an anesthesia company, I'm a CRNA by training. I graduated anesthesia school as a CRNA in 2000. So about my third year of practice, I was offered to put in a proposal for a small rural hospital to provide OB anesthesia services at that location. And I did, and it was accepted. And all of a sudden, I was not just a CRNA, but I was a CRNA in business with a hospital contract. And I would work 7 days on and 7 days off, a bit of a job share type model, doing just OB anesthesia. And on my 7 days off, I started working all around Louisiana, Texas, even a little bit into Mississippi and Arkansas back then, and started making more and more connections. And I had more and more hospital administrators ask if I'd be willing to give them a proposal for their hospital as well. And over the years, it continued to grow. And somewhere around 2000, maybe 12 or 13, we started having a little bit more substantial growth, and just really decided to invest more in the business and more in infrastructure, really put an emphasis on making sure that our clients are getting the best quality service in anesthesia, and that we can provide all the back office support and infrastructure that's required in the complex healthcare world of today. So as of now, we're in over 60 facilities in over 7 states with 400 anesthesia providers. The mix is heavily tilted towards CRNAs, but we also have about 50 physician anesthesiologists that work for us as well. 3 years ago, we brought on a 50% partner of the Catalyst Group, which is they're a private equity group, but they don't consider themselves private equity. They have a long-term horizon, about a 3 to 5 year horizon private equity group. They're more basically a family wealth management company. But the Catalyst Group is based out of Houston and Austin, and they have 30 or 40 portfolio companies that they've been involved in. And YPS was their first investment in a new fund. And the reason why we took an investment with them is that, one, we're 50% partners, so we're on equal footing. But two, they really understand a lot of the financial metrics and the blocking and tackling of growing small businesses into larger businesses, which is, somewhat our goal and part of the reason why we're having these conversations today. And they've really helped us mature. They've invested capital in our infrastructure. We've invested in a lot of technology that you'll see here over the next couple of slides. And part of the investment is what's really done is the anesthesia market right now is still relatively fragmented. However, there's about 5 or 6 national players that represent a fairly large chunk of the market. And they have a high degree of sophistication in how they manage their businesses, how they get third-party contracting, how their contractors and CRNAs are managed and whatnot. So what we think we've done is we've developed a system and we've invested capital in making sure that we bring all that expertise and all that high level of sophistication to our core market. And our core market really is community hospitals like Drew Memorial and other hospitals of similar size. We're not after the major medical tertiary centers in Little Rock. That's not our core market. Our core market is community hospitals, and we want to provide a high level of service with a high level of sophistication to our core market. Some of the investments we've made, CAM technology is what we use through our billing platform. It is, we can do a lot of unique things with CAM. We have over 150 canned reports, and we can run any ad hoc reports that we want within a matter of hours typically. And some of the good stuff that we can do is look at OR utilization metrics, on-time starts, turnover times, and really drill down to utilization. And we can share that with our clients to make sure that everyone is operating as efficiently as possible. We also, through ePreop, which is another technology, ePreop is something that we use for all of our quality metrics. At the end of every case, our providers enter their quality data that is risk stratified because it ties to the HIPAA 1500, and it gives us our adverse events rates, a lot of other metrics that we can benchmark nationally, but it's also risk stratified based on comorbidities of patients and whatnot. And we share that data with most of our clients. A lot of our community hospitals' quality improvement programs actually have a direct login and access that they can go in and view the data as well. That satisfies the MACRA and the MIPS component, and we also get a higher MIPS score because ePreop text and emails anesthesia surveys to patients after we have after we take care of them, so they can rate the individual anesthesia provider, whom we can now benchmark against the anesthesia providers in our ecosystem, and also through the ePreop's nationwide ecosystem as well. And patients it takes literally 45 seconds. It's very user-friendly. There's no login. The link they're sent automatically goes to their account with their anesthesia provider who took care of them. And they can enter a comment or two if they like. And those comments come back to us, and we can share those with our providers with the goal of making sure that our providers are always achieving a high level of service that patients are comfortable with as well. I think the last investment that we've made in infrastructure and technology is scheduling, credentialing, and payroll, all running through one app-based and computer-based program where providers can schedule time off from their phone. It goes to our corporate office. Then in the corporate office, every provider who's linked to that facility and that's credentialed to that facility can then get a notification for what shifts are open, and then they can go and fill them on their phones as well. So it makes us a lot more efficient. It ties back into payroll, it ties into credentialing. It doesn't allow us to schedule any providers at a facility that they're not credentialed at. So it's an extra layer of safety, but also efficiency. And the more efficient we operate, the more efficient we can be on our overhead. And our overhead is something that we can pass that cost savings along to our facility clients and help save them money through our efficiencies. Just a little more information about the quality. I don't think we need to get into that, but in general, we have a lot of data at our fingertips that we can share with you all as clients. These are some of the OR utilization reports. We also have our executive team. They're all kind of on the line here, our top level executives. We're available all the time, easy to reach. We have our cell phones available. Everyone will have access to us for any questions or comments. We're very, very transparent, and we stay very flexible with our clients. I'm going to knock on wood. We've never had a client terminate us for poor service or any issue such as that. And we always view our partnerships with our clients in a win-win manner. In other words, when we're coming up with a proposal, it has to work for the facility. Otherwise, if the facility and you all as boards of directors don't feel like you're getting a good product at a fair and reasonable price, then it's not going to be a long-term relationship. And most of our clients we've been engaged with for 10 years or longer. We still have all of our original clients that we still provide services for. So we talked about some of our corporate efficiencies, some of the investments that we've made from a billing and collection standpoint, which is really important because the model that we have proposed that we'll get into in the next slides is one that's a net of collections subsidy. So we have a core competency of billing and collecting, provider linking, commercial rates renegotiation. All of the aspects of billing and collecting is a core competency, what we are and who we do. So the better we are at that, the less you have to pay for anesthesia services. We've made some assumptions based on your previous 12 months worth of data on what we think we should be able to collect. And usually those assumptions are fairly conservative. We'd rather overachieve than underachieve. So we always keep that in mind. From a billing standpoint, we have a 98.2% first pass clean claim rate, which is really, really high in the industry. It's about 6 percentage points higher than average. Our billing partner has invested a lot in making sure that our claims are not only sent out fast, but they're sent out accurately and correctly so that we can get paid in a timely manner, and that we get paid the full amount that's due to us from an in-network contracts. And we are an in-network company. We do not do out-of-network billing. We do not do any balanced billing. Our billing rates are $150 per unit, which means for an average case, it's typically $1,000 to maybe $1,500 for the total billed amount for any of our services. And then they're adjudicated down to our contracted in-network rate, which is usually, depending on the payer, anywhere between 40, 50, or 60% of the write down from there. So we're very patient-friendly in billing. We are in network. We make sure that we collect the most that we possibly can from commercial payers, and then treat patients fairly if patients do have to get a bill for our services, which is not that often. Usually if they have a high deductible plan or a co-insurance or something, that's when we have to bill patients. But otherwise, we're in network and patients don't usually get a bill from us. Part of our billing software, we run underpaid claims reports. We have an IR process where our providers get trained and learn about the proper documentation for billing so that we're compliant, so that we're not having any compliance issues as well. And then we run a bunch of other ad hoc reports as well. But denials management is probably what we do best. Health insurance companies make a ton of money by denying claims these days. It values into the trillions of dollars every year of denied claims. And if you're not really strongly fighting those denials and providing the documentation and the follow-up, you're leaving tons of money on the table. We do a good job at denials management, which also then translates to a lower bill for your services. So from our standpoint, what you'll get if you decide to use our services is communication, participation, and we will be an active part of your team. Colby and I, from the clinical standpoint, for as CRNAs, we also have a medical director anesthesiologist based in Louisiana who's licensed in multiple states, who also does critical incident reviews and follows up on any adverse events to make sure that the care that was given was appropriate, and if not, how can we improve that care to make sure those things don't happen again. From an implementation standpoint, if you decide to use our services, our goal would be to retain all of your staff that you want retained. So we would work on getting those individuals under contract. We actually know them. Well, we know 2 of the 3. And our goal would be to provide you with the providers that you want. After that, if we have to recruit and hire any, we would advertise usually locally, then regionally, and then nationally to find the right providers that fit your culture of your institution. Then we have a pretty complex vetting system of phone interviews. And then as much as the facility wants to be involved in who we bring on as anesthesia providers, we allow the facility to take part in that for phone interviews, face-to-face interviews as well. just so that we're all in line and making sure that you're getting the right providers that you want for your facility. And from a financial standpoint, we have to link all the new providers for billing and collections. We have what's called a new location data sheet, where we add your facility as part of our ecosystem for Medicare billing and government billing. And then we build out different performance measures and standards for our financial reporting. So this is the last slide. Hopefully I didn't take up too much of your time today, but I did want to kind of let the board know who we are, what we do. Pretty abbreviated fashion. I rushed through it out of respect for your time. I'm sure your agenda is pretty full today and you have a lot of other things to discuss. And so out of respect for your time, I did want to give you a summary of who we are and what we do. From a financial investment standpoint, I mentioned we do a net of collection subsidy, which means each month we would bill and collect patients. At the end of that month, however much we collected would come off of our baseline floor, which is set at $69,408 in the proposal that we sent. And that's inclusive of all costs, whether it's just travel expenses, hotel expenses, recruiting expenses, if we have to hire or if we have to pay headhunters to help us find providers, everything is built into that cost. There's no added cost that we would ever build a facility for anything under this model. Using that example, we looked at the $69,408 a month. If we collect $50,000 the preceding month, then the invoice would be $69,408 minus $50,000. So is that $19,408? Sorry, I'm trying to do math in my head, but you get the point. So whatever we collect, yeah, I'm from Louisiana. Math's not our strong point down here. So I figured Arkansas would appreciate that. Whatever we collect each month would come off of the floor. And our AR will take some time to ramp up, usually about 6 months. So what we do, instead of having the first 2 months sending a very, very large invoice because our collections are going to be very low for the first 2 months, commercial payers, government payers, takes a little time before your AR gets rolling smoothly. We would do a fixed amount for the first 6 months of $22,000 a month. And then after the 6th month, we would start the adjusting based on the baseline floor compensation. We share all of our metrics with you, all of our AR data, anything that you need, any ad hoc reporting, any type of accounting that you would want to see, we're a complete open book. The question we typically get in these arrangements is, how do we know you're doing a good job of collecting? How can we trust you? Well, it's a tough thing to answer, but one of the reasons is over 50% of our clients are non-subsidy based. What I mean by that is we're fee for service at over half of our clients. Our billing partner, our coders, our collectors, everyone on that side of the business has no idea which of our clients are subsidy based and which ones are fee for service. So we go after every dollar just like it's a dollar in our pocket. And they're completely blinded to that, which really gives us some assurances that all of our clients are getting the best collections that we can. So with that, kind of rush through it, I'd like to open up for any questions, whether it be questions about us, questions about the model, or any type of implementation as well.
Tracy, this is Mike. Couple of questions. How difficult or what will be the challenge in staffing a rural facility? We really are promoting ourselves as a premier regional health system. So the coverages, is coverage certain hours or is it 24/7? Can you speak to that?
That's a great question, Mike. Just as a side note, we also provide services at Medical Center South Arkansas down the road for you all in El Dorado. So we have a presence there within about a 60-mile radius. And we're fully staffed right now. We have 6 CRNAs on staff and an anesthesiologist, with a couple of individuals who have applied recently for jobs there that were full and can't take them. So I think from a recruiting standpoint, I think we're going to be able to find high quality individuals fairly easily in today's marketplace to make sure that you're getting quality services. And then the question as far as the number of hours, we would have someone available 24 hours a day, 7 days a week, 365 days a year. Usually, because of the call requirements and how busy we are, We usually do that in a job share manner, which means we'd have one CRNA on either 7 days in a row and another one on 7 days in a row, and they would rotate off. But we would also have another CRNA available Monday through Friday, 7 to 3, to help out during peak time and busy times as well. So we would have 2 CRNAs available Monday through Friday during ordinary business hours, and 1 CRNA available 24/7, 365.
Thank you.
Tracy, this is Robin McClendon. Question for you on the amount 69,408. Is that, help me understand, is that a set amount regardless of the amount of work that's performed in a month?
So correct. That would be considered a baseline floor, if you will. So every month, or another way to look at that would be considered a guaranteed income. So if the hospital were to do 0 cases, that would be, and we'd have 0 collections, that would be the amount owed to us. We know that's never going to happen, especially after we're open for 6 months and everything is rolling and everything is mature. We take the risk on the first 6 months of getting the financials up and running. So what happens is after the first 6 months, if you guys recruit another surgeon or another obstetrician and you start getting busier, the more cases we do, the more collections we get. And the more collections we get, the closer and closer we get to that 69,408 number that that would be less and less that the facility would have to pay. So you're rewarded through your efforts of bringing in new business in our contract. Does that help explain it?
Yeah, I guess what I was asking is how long, I mean, should we, once we get really rolling here, how long is this 69,000 good for? Are you going to come back in a year and say, okay, now our base is 80,000? That was more like my question.
Okay, good question. Sorry, I misunderstood it, but maybe explaining it the other way helped as well too. We typically do 1 to 3 year contracts. On something this size, I don't think that would need to change unless the market for CRNAs start changing drastically. What I mean by that is if all of a sudden there's a CRNA shortage and prices start escalating for salaries, and we have CRNAs that decide to leave or come back to us and say they're going to leave unless we give them a pay raise, we're somewhat of a victim of that market as well. If that were to be the case, I think we would all sit down together and try and determine whether or not there needs to be an increase in our baseline guarantee. I'm fairly confident that 2 to 3 years, this should be a stable rate. Hopefully 5 or 10 years. Hopefully 5 or 10 years. I just think the CRNA market is strange. When I finished in the year 2000, there was an extreme shortage of CRNAs. I could have basically kind of thrown a dart at the U.S. map, and wherever it landed, I probably would have gotten 3 job offers in that area for pretty good pay. Then all of a sudden, we started graduating a lot of CRNAs, salaries started going down. Every time we would run an ad for a position, we would have sometimes 30 to 35 applicants within 2 days. And then we started seeing a shortage again. Just before Corona hit, there was a shortage of CRNAs. Salaries were rising rapidly, and we'd run an ad. We may get 3, 4, or 5 quality applicants over the first week. But now with Corona, there's a lot of CRNAs back in the marketplace looking for work. Hospitals are slower. Ambulatory service centers tend to be a little slower. And the market has really cooled off. So I think we're in a fairly good place right now.
Tracy, this is Scott, and I've got a couple questions for you. One, do you guys become in-network providers for third-party payers by and large, or are there any that you remain out of network on? And do you balance bill in those situations?
And then, oh, I'm sorry, go ahead.
Well, go ahead and answer that, and then I'll ask you another question after.
So we're 100% in network. It's our model. It's part of our ethos about who we are. If we have to bill out of networks and balance bill patients and potentially put patients in bankruptcy for an anesthesia services, just because we could not come to terms with United, Aetna, or Cigna, I would not sleep well at night. I would not be able to live with myself if I had to do that. It's just not part of who we are. It's not part of our culture. So we are a 100% in-network provider. Sometimes when we go into a new area, there may be a small commercial payer that we've never come in contact with. Once we do, we see the out-of-network adjudication. We take care of the patients to make sure that they don't have to pay a lot out of pocket, and then we contact that small company to become in network with them.
Okay. One of the challenges we keep having with our CRNAs, our anesthesia providers, and our surgeons is, I think the the big issue is the lack of communication. But because there's a poor communication, we keep having challenges on things like cardiac clearance and disagreements around when cardiac clearance should be received and when it should not. And what drives us crazy is whenever we have a patient who's being prepped and the CRNAs look at the chart for the first time and decide, hey, this patient needs to be cleared from a cardiac standpoint before we can do anything. So what do you guys do? Have y'all run into that issue before? And what would be your approach to handling that situation such that we don't have to keep constantly dealing with it, et cetera?
Yes, sir. Great question. We run into that pretty frequently when we take over facilities that haven't standardized that process. What we would like to do is Colby and I would meet with the medical executive committee and the CRNAs, and we have tons of examples of a standardized process for screening and who requires it, who doesn't, what the process is, why it's required. And then we would like to sit down with the medical executive committee, or at least the surgery committee, and then hash that out so where everyone can agree on what's appropriate for the standard of care. We bring studies of what's going on out there in the marketplace as well, and the literature about what's safe and what's not. And then we would set it as a policy and procedure. So the surgeon's offices would have it, the anesthesia department would have it, pre-admit testing would have a set of guidelines. So that way everyone knows what the goalpost is, and it's not moving all the time, and it's all agreed upon. And then anytime something is urgent or emergent and has to be done anyway, then it falls out. You just have to do what needs to be done at that point. And from an anesthesia standpoint, you take care of the patient as best you can and as safe as you can once that happens. But that's how we typically handle it. Then once everyone kind of sees it, it becomes a much easier situation and an easier conversation. And the amount of calls we get from community hospitals related to this topic, when we first start a place, before we implement these types of guidelines, we get a lot of phone calls back to us with questions, and upset surgeons, right? And upset patients as well. Once we implement these, the calls drop to almost zero.
Thank you.
Yes, sir.
Tracy, hi, this is Jenny Guthrie. I'm the revenue cycle director here at the hospital. I'm just curious, do you guys follow your clients' charity care policies? For instance, if we have a patient that, and our policy is, based on federal poverty guidelines. So we may have a patient that qualifies for 25%. We do 25, 50, 75, and 100. So would you guys go along with that, or do you have your own policy?
We do not. We use the policy of the facility. Okay. Brian, as our Chief Operations Officer, and John Mendel, our CFO, is on the line as well. But we follow your policies based on who should be charity, who shouldn't be charity, what should be written off, and what should not be written off. At the end of the day, through the model that we're proposing, it's essentially your dollars. So we want to collect as much of your dollars as possible. But if you tell us this patient has a 50% charity allowable, then that's fine. That's what we'll do. So we take guidance from you. And Brian or John, you have anything to add to that?
No, sir. That's it.
Thank you.
You're welcome. I was hoping one of them would chime in just to give me a break from talking.
Any more questions? This is Leah, and I just wanted to say, Tracy and team, John, Brian, Colby, thank you so much for the last couple of weeks working with me, and thank you for presenting today to our board.
No, we're very welcome. It's been a pleasure to work with you, and look, we're just happy for the opportunity. And if If you decide to stay with your current provider, we wish you nothing but the best of luck. But if you decide to come with us, you'll get 100% of our attention to detail and making sure that the transition goes as smoothly as possible. So happy to field any other questions. If some questions come up later, or if you think of something that after you're like, oh, I forgot to ask, Leah has all of our contact information. Feel free to reach out to me or any of our team members, and we'll be happy to respond.
We sure will. Any more questions for them?
Yeah, I do have one for you, Tracy. If we were to go with y'all, how long would it take to get this going, get this relationship started?
We usually we prefer 45 to 60 days, sometimes upwards of 90 days. We can do it much quicker than that if needed. The reason for the time is to make sure that we get all the paperwork done for the payer linkaging and the billing and the collecting, get the providers under contract. Those things tend to take a little bit longer in today's healthcare system. But if we need to do it quicker, we can certainly do it quicker. But our preference would be 45 to 90 days.
Okay.
All right. Well, I will stop sharing my screen, and we're available for any questions or comments after your meeting or later. Just let us know.
Okay, thanks, Tracy. It's a good presentation.
Oh, thank you all, and sorry for the delay. I was trying to log in, it kept spinning. So y'all have a great day.
Thanks, Tracy.
Thank you.
Thank you, guys.
Thank you.
Okay, Stephanie.
Yes. Can you hear me now?
Yes. Yeah, I hear you. So what we moved to?
Yep. I just sent about 5 minutes ago, Sweet Dreams an email and asked them to go on and start logging in.
Okay.
I do not see them yet, so. And they haven't replied to my email. Need some Jeopardy music.
Well, while we're waiting, Leah, Scott, Melody, how does that floor, that net number compare to what we're spending now?
Well, that number is double monthly. However, there are a lot of variables in there. Specifically, probably why Sweet Dreams has decided to renegotiate their contract with us is the $10,000 stipend is currently in the market very, very low. What YPS is has stated that the 21,000 is much closer to what I'm finding, or what Melody and I are finding is more market value at this time. Their services, and I think they pretty much speak for themselves. Very reputable company, and have a lot of great benefits.
Okay.
Leah, you don't happen to have a number to text that Nikki by any chance, do you?
I do. I sure will.
Okay, you can text her. I emailed, but I haven't responded. Heard us respond. However, I did tell them to sign on originally at 11:15. So even if they're not getting our emails, they should be on within 5 minutes.
So Sweet Dreams is the company that we have been with for a couple of years now. And when they first contracted with us, it was told to us that they'd be able to do this without any subsidy. They partnered with us. We started working together. They came back about, a year and a half ago and said, hey, we're having trouble collecting enough money to cover our expenses. We didn't realize that the Arkansas market was going to pay so poorly, so we need a subsidy of $10,000. We went ahead and started paying that to them, I guess, about a year and a half or so ago. Here recently, they sent us a termination notice, and our contract calls for 90 days notice. So we started talking to other anesthesia providers. YPS is one that was willing to give us a proposal. We had a couple of them that didn't want to propose, said we were not the right fit for them, so we did not get a proposal from them. We've got so anyway, long story short, we've got YPS's proposal, Sweet Dreams' new contract proposal that they'd like us to enter into with them, and we have a proposal from Baptist. They all seem to be in the same ballpark in terms of cost.
Okay, so Sweet Dreams presentation is going to be basically, we want to stay with them to increase essentially about double where we currently are.
Yeah, they're they're at the point, since they've been with us for a while, their position is, well, we know what our baseline costs are and we know what we're collecting, and so we need you guys to subsidize us to that baseline. So, and they'll go over those details when we get on the call, when they get on the call. I think they're going to show you numbers that are going to be a bit lower than YPS based on their history with us.
Yes, but what they're not going to be able to show you is their lack of participation and communication. And all those metrics that YPS talked about, to my knowledge, I've never seen, in my year, I've not seen any of those metrics being monitored through Sweet Dreams.
Leah, did you hear back from Nikki by any chance?
No, I haven't found her number yet, but I'm on it.
Oh. Okay.
Don, you'd ask them about that this way. You'd ask them about the communication with the surgeons. Is that a pretty big issue right now?
I'm sorry. I missed that question.
It was for Scott.
Oh, okay.
It hasn't been nearly as bad here lately. Of course, we haven't been doing a whole lot of surgeries lately, but in the recent past, it has been, and it's been frustrating to our surgeons doing work here, even our employed physicians. And one of the things that would irritate me the most is, instead of the CRNAs that we have going to surgeons and working through whatever conflict they have, they would take that to the nurse manager or the OR director, and that OR director would be caught in the middle of that conversation. And what ends up happening is the patient ends up getting poor care or poor quality service, and everybody gets frustrated. So,
hi, Nikki.
Hello. Okay, I think Nikki's on here.
Yeah, can you hear me?
We can hear you, Nikki.
Okay.
Now we can see you.
All right. That's good, I guess. I have Richard, he's in the next office over, so give me just a minute. Hey, Richard. Hey. Yeah, I've got it on my computer. I can try to put you on. Yeah, let me send it to you. Hold on. Okay. I'm going to share the dial-in number for Richard. Okay. I just shared it with him. Sorry.
I thought I sent him that email a couple times, but
yeah, he
didn't
doesn't have a camera, so he's just going to dial in.
Okay.
Stephanie, did you receive the 2 attachments that I shared to reference?
Oh, I sure have. Let me forward it out to the board real quick.
Please. Thank you.
Okay. Mhm. To the board members if you're on your computer, I just emailed I guess it's a scanned object from Nikki. You don't have any way Nikki, to share that on your desktop, do you? Do you know how to do that?
I do not, but I can look and see.
Up in the left-hand corner, it should say share. And I believe you can click on that and it
Stephanie, it's not letting me.
It's not? Okay.
No. Like, okay, hold on one second.
Rusty, you on the call? Yeah, with Stephanie.
Yes, sir.
I think that Zoom product is a lot better than this Cisco product.
From my understanding, Zoom is not confidential at all. I think we've got some emails, but
AHA uses it, and they try to remain confidential in those meetings. So I don't know, just be worth checking into.
Okay, I'll talk to Rusty about it.
Maybe that's it.
Okay, I think we have Richard on.
Yeah, I'm here.
And Nikki, you said Jenny was able to put what you emailed out.
Okay, I see it. Thank you. So are we ready? Would you like for us to?
Yep, we're ready.
Okay. Sure. All right. Well, thanks everyone for allowing Richard and myself to join your board meeting. What I have shared with you, we had sent this to Scott, I guess, several weeks ago when we first had our initial discussions. As you all are aware, we've had the anesthesia contract there at Drew for 2 years now. Our goal for working with any of our hospitals is to go in. We're guests in your house to fully staff, provide the best anesthesia services, and at the lowest price to the facility. We started off with no request for stipend. We then worked with Scott and his team and have revamped the contract where they were Drew was paying us $120,000 a year, which again, from our perspective, was the lowest that we were anticipating to be able to work with. And then we have continued, unfortunately, losing some money there. And I know Richard, he's our CEO. He will talk in just a few minutes, but just to give everybody a quick overview. So we have had discussions with Scott and with Leah with what next steps for us could be. This also came up at a time in which we're losing one anesthesia provider, who is Hugh Fortenberry, one of our Monday through Friday folks. So we've had a lot of things going on here within the past couple of months, aside from COVID, that we're all dealing with. But before I talk further, I wanted to introduce Richard Doberly. Richard is our CEO, and he is a CRNA, and he's one of the owners of the company. So with that, Richard, would you like to jump in?
Yeah, sure. I'm sorry, I dialed in late. I don't know who all is on the call.
Richard, this is Scott. You've got senior leadership from the hospital on the call, as well as all of the board members. We have 7 board members.
Okay, very good. Well, to follow up on our last conversation, Nikki put the numbers together, and we discussed this last time, and I think you guys have the handouts. We had a carryover loss of from last year of $162,000. That's actually improved over the first 4 months of this year. So our current loss is about $75,000. And we talked about the cost plus model, trying to figure out something that works good for both sides. We've done this recently at a few other hospitals and some of the surgery centers. And I like it because it's got a benefit for both parties. And Nikki can go over the projections she put together. But for example, right now we just got kind of a fixed stipend. So no matter, what happens, that's the amount of money that you pay. But in this situation, as was the case in February and March of this year, we actually had a profit. So in those months, the hospital would have paid nothing to us. And I know you guys are working to get new surgeons and increase volume and that type of thing. So if that occurs, we meet our cost at plus that 20% profit margin, then the hospital wouldn't know anything at all. So that's kind of the idea behind moving to the cost plus model. And the loss is what was pushing us to figure out something maybe new and better. And so that's the background on that. Nikki put together, I think, what you guys have in front of you, the projections, based on what we have experienced the first few months of 2020. And Nikki, I don't think I have that in front of me.
I'm gonna bring
Maybe you can go over that part. Oh, thank you. Okay, she just brought this in. Let's see. Have you had a chance to review this, Scott, or anybody else? Do you have any questions about it before we kind of go through this?
I reviewed it, but go ahead and give us an update from your vantage.
Nikki, I'm gonna let you talk through this since you put this together.
Yeah, no, I'll be glad to. Can you go back to the first attachment? There you go. So just so that leadership and the board will be aware, when I put this spreadsheet together, I was able to actually look at all of the numbers, the payer mixes specific to Drew, since we've had a solid year's worth of data that I could plug into. This was based on our actual reimbursement for, as you see, Aetna, Blue Cross non-par, Blue Cross par, which means in network. So you can look at the column that says 2019 all balances by insurance, and then 2019 zero balances. So from our perspective, we look at it both. The all balance, that's when cash flow is just consistently coming in based on the cases in which we've billed for. The zero balances for us means all of the anesthesia cases that our billing company has billed and collected, appealed, and there will be no additional income coming in. So we call that our zero balances, meaning the account is closed. So as you can see, Aetna, we're at $311.79. Blue Cross non-par was $267.38. When we first arrived there, we were billing everything out of network for Blue Cross. However, we have, as you can see the difference there, opted to go in network with Blue Cross, and it essentially doubled our income for the Blue Cross plans. We have Cigna. So as you'll see with Cigna, initially we had really good reimbursement, and then it drops down. So we had to actually issue refunds by the time the accounts were settled. So going all the way down, the highlighted in blue, you'll see all payers combined, and that's our average reimbursement. So we're looking at approximately $390 per case. So when we apply the at that average reimbursement, you'll see in the far right column projection based on zero balances. So that's once the claims have settled. We're looking to collect about $810,000. Because of the 24/7 call, and then we have a Monday through Friday person, Hugh, or we're actually in search for his replacement. Down in the center block, you will see the actual expense block, and we're looking at a little over $900,000, $958,000. So when we apply the 20% cost to this model, we're looking at, it's kind of small, $1.15 million in total expenses, including the contract labor, billing, our billing component, and our administrative fees, which covers, again, from our end, the processing of all of the claims. So you'll see that there. And if we took just strictly off of 2019, there were 1,997 cases that were billed for, and then based on this payer mix and reimbursement, again, we would have expected at that point in time $810,000. When you apply the cost plus model to the collections, you'll see down at the very bottom, highlighted in yellow, what the cost plus 20% could be, what that balance would be that could be owed. Now, on the second page, if somebody could move it, there we go. Thank you. This is our actual P&L for the first part of this year through April. As you'll see here, we're only, you'll see our actual collections it listed as income. And then the second, you'll see locum tenens income. And that's actually that along with the income guarantee, that's your $10,000 per month that you're paying us. So I did not include that in our income collections, actual collections for billed cases. But all that you'll see that we're expensing to you guys right now are our billing expenses and our contract labor. It does not take into account any of our administrative fees, simply because there's nothing left there to cover for those expenses. Our whole goal, again, you'll see the carryover loss of 162,000. We've had profitable months in January, February, March, and April, so that's good. It helped to chip away at that carryover loss, and now has it down to right at $75,000 loss. But you'll, as you see, we're not able to expense our administrative fees to this because of our unprofitability, including the carryover losses. So as Richard was saying, if you look at January and looking only at the 64,237 collections, and you subtract the 78,000, right at 79,000, which includes the expenses plus the 20%, which would cover our administrative fees. Drew would, based on the actual numbers, would owe us $14,747. In February and March, you would owe nothing. And then in April, based on actual numbers, you would owe $17,552. The question has came up, and we've had great meetings with Leah and with the administrative team there, with adding someone that can help out with OB call, possibly adding a third provider. We can certainly recruit. That just simply makes our cost go up, which with this model would also make the amount that Drew would be invoiced go up. We can do as much or as little. We have been able to, with the COVID, we were able to cancel Hugh several days, and that will certainly be reflective. You can see in the month of April, it was down. And then in May, we were able to cancel him also some days as well. And I apologize that we don't have the May numbers to you guys yet. But I can certainly, Scott, provide that to you at a later date. So that really gives you our projection template was the first page. Without looking at what the actual income was, it came out pretty close as far as the collections goes. But when you apply this formula to the actual numbers, which are January through April P&Ls, you can see what the end result would be. And that's basically 2 months worth of invoices that Drew would be subject to paying.
Nikki, this is Mike. What do you attribute the February and March numbers to? They were really strong income months. Were volumes just that much better? Well,
when you bill insurance, typically you're paid within 45 to 60 days. So you're looking, and that's Medicare and in-network payers. So you're looking at the peak months, and this is the reimbursement that's coming in for, say, October, November, December, which is our busier.
Okay.
Patients have met their deductibles, and
Right.
so the income is expected to be more.
Okay.
Nikki, this is Robin McClendon. Just so I'm understanding, on your chart here that we're looking at on the month of April, if we were doing the cost plus deal, and we would owe the 17.5, but that's after the 10,000 additional payment from us. Is that correct?
No, I actually did not include the payments that are each month. You'll see the 10,000, and I apologize that they're not both on the same row. Our CFO has corrected that for the month of May, but I did not include. If you'll look at the yellow row, it says income collections. That 36,808 is, I'm sorry, 806. That's actually from billed claims from insurance payers.
So the 17,552 that we would pay you would be a total cost for us, not 17,500 plus 10.
That's correct. Yes, ma'am.
Okay, thank you.
You're welcome. And Richard, did you have anything else? I know you've looked at the numbers with me that I may not have brought up.
No, I don't. I think you covered everything. Yeah, I think you covered everything well.
This is Wayne. Once you got everybody, all of your stuff in network, that's when it appeared to get a whole lot better, right?
If you can, we're in network only with Blue Cross. For us, the benefit is being out of network. Certainly that helped as far as going in network. It's really, we always describe it as like a puzzle. We go in and we try it the way out of network first, because once you're in network, you never really go back with the insurance payers. So we attempted it out of network and it didn't pan out for us. I would say within 6 months, the majority of the providers were enrolled. We actually pulled claims so that we could go back and have those claims retroactive. But as you'll see with the first spreadsheet, the first page of what I emailed, our reimbursement for the out-of-network payers, it is certainly better. Cigna is a little over $600. UHC was up. Yeah, thank you. So as you'll see, when we're able to collect $1,600 from a payer, that would cover at least one of the CRNA's daily rates. So if we don't, let me back up and just say, if we don't use the providers that are there, we have one that's on call 24/7. We're going to pay them regardless because they're on call. If we can staff and shift up or down as needed, we're able to control the cost with your Monday through Friday folks. And that certainly helps us. And we try our hardest to be as efficient as possible. The good problem is, and it's a good thing, that Drew is getting busier. So we need that second provider, and there may be days in which we need the third, and it can be justified. But if, again, we have one United Healthcare patient that comes in, that's basically paid for at least one of the provider's daily rates. We pay them if they're there for 2 hours or if they're there for 10 hours. They're paid a flat daily rate. Scott, is there anything else you'd like for Richard or me to cover?
So, excuse me. The new arrangement would be for us to go from 3 providers down to 2 providers. Is that correct?
Well, we have staff use 2 providers. We have Levi and Ed. They rotate. They're on 7 days on, 7 days off, so they're 24/7 call. And then we have Hugh Fortenberry that's there Monday through Friday. So that's our current staffing. We are in the process of recruiting for Hugh. We had actually hired a gentleman, and he was within a 30-mile radius, so he was a local. And unfortunately, he's had a health situation and is unable to come on board. So we're actively recruiting for.
And do y'all anticipate any staff turnover going forward?
I communicate often with the providers. I did let them know because a small town, people hear things that we were in the process of working with you guys on an updated contract, but I didn't want them to hear anything through the grapevine. So I've reassured them that we're planning to stay. We hope that Drew will consider us to still be a partner with you guys, and have reassured them that we have no plans to make any changes. So that's not the plan. We don't anticipate Ed nor Levi to leave.
Okay, thank you.
Okay. Now, Scott, I did want to add one thing. If you guys opted and said we're going to give notice, we're not going to renew this contract, we are obligated to a 60-day notice for our CRNAs. So contractually, they're bound. We're bound to them for 60 days. So we did want to be able to communicate to them, in advance. Also for us to avoid having to pay them after a contract possibly terminated. So I know the purpose is for you guys to make a determination, and we hope to be able to hear back from you just as soon as possible so that we can communicate with the providers as to next steps.
Yes, thanks. And we're pedaling fast trying to get this done.
Okay.
So we'll let you know as soon as possible.
Okay. That will be great.
Thank you, Nikki, for coming on the call.
Yeah, no, thank you for allowing us to talk. And if anyone has all right, well, I guess if no further questions, then we can pop off.
Okay.
All right.
Bye-bye.
Thank you very much. Bye-bye.
Okay. Scott, is Baptist making a presentation, or are we just going to talk about it?
Yeah, we're just going to talk about it. They sent a letter with their proposal late last week. I did receive an email today from Doug Weeks. He's I guess like the COO for Baptist. Anyway, he told me. Let me pull this up. He said he didn't notice. He wasn't aware that that his team had sent the proposal. He said he can't find his notes from our phone conversation, so he didn't remember if the quote they were giving us was in line with our expectations. He said, what I tell you is that we're open to other ways of doing this and assisting. If this doesn't work for you guys, just call and we can set up a discussion. The long and short of their proposal is if we do 150 cases in a month, the subsidy's $20,000 per month. If we do less than 150 cases per month, the subsidy is $30,000. So it's a pretty basic proposal. I know they're eager to do something with us, but we'd have to go back to the drawing board and have more discussion with them.
Did we have somebody in between Sweet Dreams and had our own people on staff? Or did we go straight from when our CRNAs left, did we go to Sweet Dreams at that time? And have
No.
been with us since?
Yeah, we went with another company. I don't remember the name of that group. I think we reached out to them again. Anyway, we were with someone else, and that relationship started out very rocky, and it sort of improved toward the end, but Sweet Dreams came into the picture and said, hey, we're going to do this and it won't cost you guys anything. So it was a pretty simple decision at that time to make the switch to Sweet Dreams. And that's who we've been with for a couple of years now.
So our experience with outsourcing this has not been good or great by any stretch of the imagination. And this is, unless I'm missing something, this is about a $800,000 or $900,000 a year proposition. Do we want to entertain it all? Trying to go out and find people and bring this in house, or is that too overwhelming, or is there any comments or opinions on that?
So we used that approach before. The challenge with that approach is finding the staff, and we had 2 CRNAs. Of course, we weren't doing near the number of cases we do now. And what do you do when one of them goes on vacation or gets sick or takes another job and leaves us? That's the big benefit of having a third party manage this service for us.
This is Carl. How much time do we have to make a decision to get these things locked in?
The Sweet Dreams contract would be up August the 8th. So we need to make a decision pretty quickly.
Well, an outsider not understanding anything about what goes on with the actual providing. First presenter was very impressive, and I don't know if the metrics they talked about would be of value to the facility doing a better level of business and a better quality of business, but it looked to me, it sounded to me they were extremely professional and understood the business from top to bottom. And in the long run, those kind of things are usually worth something. So based on what I've heard, if we have to make a decision on what to do, that first group really impressed me.
I agree. I think Melody and I have been working with these different companies, and they by far are, to me, stand out above the others. They are ran by anesthesiologists and CRNAs, and they've just been a pleasure to work with. They're here in Arkansas. I think one of the benefits is that they are in the El Dorado Hospital. There could be some opportunity there to, for staffing when we needed it, and vice versa. I was disappointed in Sweet Dreams in that it wasn't as if this call was important to them. As important to me as it should have been to save the contract with us and to show us that they want to continue being partners with us. And I personally didn't see that.
From a quality.
There was one other item that I'm not sure I'm clear on. In these numbers, the second group was providing. They talked about an $810,000 zero balance and a $777,000 all balance. I don't know what that means, but if you look at either one of those numbers on a monthly basis, one is 67,000 monthly, and the other was right at 65,000. That's what they're talking about. That they anticipated as collections. That's almost exactly what the other company, if I'm remembering it correct, wanted a guarantee on.
Mm-hmm.
So if those numbers are good, it would appear we wouldn't be spending much money for their service because they would be collecting that much.
I think that's where those quality metrics that they proposed with YPS come in, because I think they document better, they're more engaged, and they will collect better for us. I don't know anything about collections or money, but just based on the information they provide from a quality standpoint, they're going to have to document better to capture that information.
I do know that the metrics are very important to the efficiency of our OR with the utilization, such as the on-time starts, the turnover times, for them to collect that information and help us to drive some changes and more efficiency in the OR does equate to financial gains.
So it's going to be a lot like staffing an ER with ER physicians. Anytime you talk to another vendor for ER staffing and say you make the switch, more often than not, you end up with the same doctors. I would think that we'll end up with the same providers, at least initially. I don't think any of that will change regardless of who we go with. They're all going to want to employ the people that are on staff now. One of the reasons I asked about turnover for Sweet Dreams is it's my understanding, and I think, Leah, you shared this with me, that Ed is talking about walking away if we continue with Sweet Dreams. Is that?
Yes, that's correct. That is correct.
Okay. And they've told us they've had a very difficult time recruiting. YPS is saying the recruiting environment is the best they've seen in a while because demand is not that high. So I'm a little confused between one company's message and the other company's message. I would think that it makes more sense with what YPS is telling us, that there are a lot of CRNAs out there looking for work. So I'm wondering why is Sweet Dreams having such a hard time recruiting? Do you have any insight into that?
I do not. I haven't had any of those conversations with them.
Well, we did talk about it on our last call with them. And what I remember them telling us was they're paying the providers maybe a little less than market value because they're trying to keep their losses down. and that if we want them to be better at recruiting, we'd have to pay more? Is that kind of how you remember it?
Yes, definitely.
Well, on the proposal from YPS, am I understanding this correctly that our exposure, our expense is always going to be in that 20,000 range? I mean, if volumes pick up, we'll still be obligated to about that 20,000 a month.
We're going to be obligated to 22,000 per month for the first 6 months. And then after that, it'll be similar to what you just saw, where they back out collections and, we figure out what the balance due is at that point. But they're saying it's going to take them 6 months to gear up and get their collection efforts up to speed. Melody, you agree with that? Did I read that correctly?
That's correct. The difference between YPS and Sweet Dreams is for YPS, we know the floor. We know that amount is $69,408, and it's going to be reduced by whatever they collect in the month. So if they collect $70,000, then we won't owe them anything. With Sweet Dreams, their model is cost plus 20%, and that cost could vary from month to month. So we don't know exactly what that's going to be. And then that will in turn be reduced by collections. But again, we don't know our exposure because we don't know exactly what cost is going to be. They've estimated it at 1.1 million, almost 1,150,000 is what they've estimated their cost plus 20% to be. If you take YPS's 69,408 times 12 months, that's 832,000. So there's a difference there, and savings to us.
Once again, I just want to be sure I'm understanding. What did the second presenter mean by $820,353 of zero balance? What does that mean?
So their zero balance accounts means that the account is considered fully settled.
All right. So did they collect that much money?
Yes, that's what they're estimating that they would collect on fully settled accounts.
All right.
So an account that has gone through the entire process, and they got the balance to zero somehow, whether they collected it or wrote it off.
All right. Well, that's $67,000 a month, which means,
correct,
going back to the first presenter, we would end up owing them $2,000 a month, which is correct, a lot less than $20,000. And it just looks like to me, if this is what we're already doing based on Sweet Dreams' record with us, there's not much exposure to go with this first group.
Agreed.
So if we decide we're going to go with YPS, we probably need to make that decision quickly. We need to get this agreement over to Tim to get it reviewed and get that turned around as quickly as possible based on YPS's timeline for getting started. And it still may require us to have a workaround if there is any time gap between when the contract ends with Sweet Dreams and when it starts up with YPS.
Have we talked on radio? Are they very happy with YPS?
Yes. So I reached out to the Arkansas Rural Health Partnership whenever we got the notice from Sweet Dreams that they were terminating our current agreement, and asked if I could find out what other facilities we're using. Several facilities around us are staffing themselves and then use a billing company. The only actual response that we received from another facility, other than those directly surrounding us, was from El Dorado, and they use YPS and have been extremely satisfied with the service that they receive.
Well, I agree with Carl. Their presentation was much more professional, and they're much more impressive than Sweet Dreams, if that means anything.
Yes, and we got Tim's analysis of the new contract that Sweet Dreams proposed. The three big differences is from the current contract is that they do want to reduce from 3 to 2 CRNAs, which before pre-COVID, we were our volumes looked good enough that we were wanting an additional CRNA at times. So that's the first big difference. And then increase in chargers. They're going to increase the charges to our self-pay patients. And the third point was the cost plus 20% fee structure. He says it's been his experience that can be difficult to negotiate because the hospital's essentially given the vendor a blank check. So that was from Tim and his analysis of the existing and the new proposed contract for Sweet Dreams.
Well, I don't know why it doesn't appear we have much of an opportunity to make a first and second choice, with either the second one being very good. Baptist wants 20 to 30,000 a month, regardless of what we do. It doesn't matter how much you grow the business; they still want 20 or they want 30. I don't like that proposal, and I don't like the fact they didn't give us a very, a very informative proposal either. So, in the interest of time, I'm going to make a recommendation or suggest that make a motion that we select this first presenter as the provider for our anesthesia services.
Okay, I agree. I don't think we have the luxury of time here, and they do seem to be well respected in the. So, not to belabor it, Carl has made a motion that we go with YPS as our anesthesia provider. Does anybody want to second that? And all right, we got a motion and a second by Wayne Owen. All in favor, say aye.
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 Any opposed? Okay, motion carries. All right. The next agenda item is we need an approval of the board minutes dated May 27th, 2020.
This is Jay, so moved.
I'll make a motion.
Who made the motion? Wayne?
Yeah, it's one.
Jay, you want to second it?
That's fine. Yes, sir.
Okay. Motion by Wayne, second by Jay. All in favor say aye.
Aye.
Any opposed? Motion carries. Okay, that moves us into financials. I've got some packets. Melody, you want to go into those? Go over those?
Sure. Savannah has already touched on a lot of what I was going to point out. Our admissions were lower in the month of May than we anticipated. We took a dip in April and didn't anticipate May being as low as it was. So that contributed to a lower inpatient revenue. However, our observation admissions were higher than expected, so our outpatient revenue was a little bit higher than what we expected. Our inpatient surgeries were higher than what we expected as well, and outpatient as well. Home health has been increasing in their census since they declined to about 158, I think was their low. But they've been moving up. So we're starting to see some of those departments increase while others are still either holding steady at a low census or declining a little bit. For the month, we were right on budget with our operating expenses. We were just a little bit under. And then we had grants and contributions. We received $100,000 for the AEDC Ready to Work grant that we are going to be using for some marketing materials and campaigns. One of the things that we can use that for is reopening or resuming normal operations, which is what we're working with ERI on to put together a campaign on that. We received $139,000 from the Blue and You Foundation for the testing equipment that we have already submitted a purchase order for, and we're just waiting to receive the equipment. And we also received about $15,000 from a preparedness grant through AHA that we've used to buy. We used for some N95 masks in May. The other line that you see down in the non-operating revenues, the $1.2 million, that is where we recognized a portion of the PPP loan as revenue, since that will be forgiven because we've used it on eligible expenditures. We still had at May 31st, $666,000 roughly in the Paycheck Protection account, but we have since used that in June. That's fully expended as of today. I don't have a whole lot of other, like I said, Savannah pointed out a lot of what I had to talk about. So
I have one question that either you or Scott can comment on. I've never been clear on where we ended up with this 10 or 11 million dollars that we now have, 11.5, I guess, in money market. Can somebody explain where those funds came from and how many of them are ours to keep or how we're supposed to spend them?
Sure, I can answer that. We received $854,000 at the very beginning from the CARES Act funding, the first tranche, the first wave of funding that it was a $20 billion allocation. And then we received $6.7 million in Medicare advance payments. So those are going to be recouped. The $6.7 million is going to be recouped beginning around the 1st of August. And so that's part of what is sitting in that balance. In addition, we received $3.8 million from the rural funding bucket from the CARES Act. And that was what we received through May. In addition, in June, we've received another $5 million for caring for a high proportion of Medicare patients. And then, of course, we received the $3.2 million in the Paycheck Protection loan. So as far as paying all of that back, as long as we justify and document that we utilize the funds to either make up for lost revenue or added expenses, that money doesn't have to be paid back. That gets recorded and it'll flow through other non-operating revenue down at the bottom of the operating statement.
So we do have confirmation that the accelerated Medicare payments will need to be repaid.
There has not been any official information released to my knowledge that says otherwise.
There is still talk out there amongst the advocacy groups like the American Hospital Association and others, working with all the state delegations out there on trying to get those converted from loans to grants. Whether or not they're successful, we'll have to wait and see. Everyone realizes the clock is ticking on that. Last I saw, there were 40 representatives signed on, and it's being talked about quite a bit. So we'll see what happens. My guess is if it is forgiven, or at least converted to some type of grant, it would probably fall into the same category that Melody spoke about earlier, and that is we'd have to justify that money through lost revenue and incurred expenses, all related to COVID.
Okay, if we make the assumption today that it's not going to be forgiven, and we're going to have to pay it back, and that was in between 6.7. How much?
6.7 million.
Yeah. And so if we stayed revenue neutral for the next several months, then that reduces our cash position to about 10 million. Is that correct?
Well, right now, as of today, we're sitting on about $20 million. So it would take it down to about 14 million.
Well, that's where I'm getting lost. Where is there money that's not showing up in the cash account detail?
Well, we received the $5 million that Melody was talking about during the month of June. So it's not on this May report.
That's right. My bad. That's right. So it's actually, okay, I got you. So it'd be 14, roughly. If we did Medicare accelerated repayment.
Yes.
Okay.
Kind of a semi-related question on those cash funds. Do we have securities pledged in excess of our FDIC limits for those at the bank? Is that?
We do.
Good deal. Okay.
Okay. Any other questions related to financials, May financials? If not, I'll entertain a motion that they be accepted as presented.
So moved. It's Jay.
Motion by Jay. Do I hear a second?
Second.
Second by Carl. All in favor say aye.
Aye.
Any opposed? Motion carries. Okay, budget, revised budget. Melody?
Okay, so I sent a letter with the revised budget that I sent out, just trying to explain sort of what happened. I left out, and I sent a little reconciliation that went from what was approved to the new revised number. I left out in the consolidation of the budget those areas that you see, the respiratory, education, observation, and swing bed revenue numbers. And so that made a difference on the total revenue of about $15 million. It also has an impact to the contractual of about $10 million. So the net is right at about $5 million. And then they had some added expenses for those departments. So that's what that revision is. Those departments were budgeted. They just doing everything manually in an Excel spreadsheet and trying to do it as quickly as possible just missed those departments. So that's the difference. It is a positive difference for us. But that's that revision. And then I'm going to be continuing to review it after June and looking for forward to the next 3 months. and forward from there, as we discussed.
Well, obviously it goes from a negative EBITDA number to a pretty attractive number. It's just, my point is the one I was making with Savannah is it is showing 66% contractual, and we're not 2 months in. We're not close to that. So we can make the progress that that she had discussed. That'd be great. It's just, it's going to have to be below 66% for several months just to get it back to 66%.
Yeah, and so on the contractual allowances, on the way that this is budgeted, you know, it's got the 3 lines: contractual allowances, bad debt, and other. And contractuals are budgeted at 62%, and for the month of May, we actually came in at 62%. Where we're seeing the differences are going to be in that bad debt and the other adjustments. And so that's what we're going to have to talk about at this strategy meeting that we have, or the strategic planning meeting, is how do we get that bad debt? Because that's where the biggest difference is. It's coming in at 5%, whereas it's been budgeted at 3%. So that 2% difference. And then on the other adjustments, there's a 1% difference in what I budgeted and what we're actually seeing. And so managing those 2 lines is going to be where we need their help and where we need to start looking at what we can do to get those more in line.
Okay. Anything else related to the budget revision? Okay. Do we need to formally adopt this, the revised budget? I guess not. Okay, moving right along to the tickler file. You got that in your packet. Hopefully you've had a chance to review that. Scott, any comments on the hospital expansion?
No, there's nothing new to report there.
Okay.
We probably can take that off now.
That's what I wanted. Okay. All right, thanks. What about your report?
Okay, first thing I'd like to do is ask the press that's on this call to please not report the anesthesia contract until we're able to speak to our CRNAs and staff and notify the other vendors of our plans. So if y'all would do that for us, I'd appreciate it. The other thing I wanted to mention was I've been participating in a lot of calls related to COVID and the recovery and the surge that's expected to occur later this year. There is a belief that we're going to see a surge sometime around September, October, or a peak here in Arkansas, something to the effect of 150,000 positives in our state. So we're all interested to see how that pans out. The last time we talked about surge planning, we never really received a surge. So hopefully that ends up being the case this fall. But one thing we are seeing, you know, and not only us, but hospitals all over, is our ER volumes dipping. Nobody really expected to see those volumes dip. But the other thing we're seeing is the people that are showing up in our ERs are a lot sicker than what we've come to expect over the years. I think a lot of that's due to the fact that people have avoided hospitals and clinics for quite some time. I know our clinics are still not operating at the levels they were operating pre-COVID. And what I mean by that is their volumes are still off quite a bit. So what we are seeing in our ER is very sick individuals coming in. And it's pretty taxing on our staff throughout the hospital, which I guess causes a concern of people getting burned out. So to the extent that we can, try to get folks some relief and get them some time off and give them a break, that's going to be something we continue to work on. I talked to Tim Ezel, switching gears now. I spoke to Tim Ezel about a week and a half ago about the Optum situation. That is that $800,000 or so that's been sitting on our AR that we've been trying to get resolution on. The ball is back in Optum's court. We're waiting to hear back from them. This does not come without any risk. And one of the concerns that Tim expresses is, there is some gray area around how we try to adjudicate with Optum on these claims. So they may raise that, which may, cause prying eyes to look deeper, and maybe there's some risk there for us. But that's yet to be determined. What I'd like to see, and I think what everybody would like to see, is some kind of settlement on that, and so that we can move on and we can get that balance off our books. We also spoke about FCOA and kind of the same message here, and that is, we're going to probably have to continue to push them, but if we can get them to come to the realization that, we probably dropped the ball over at Drew and we need to settle this, getting them to that point in the game where we can have that conversation. That's kind of where we're trying to lead this and take this. Outside of that, I know we've got a bunch of policies and procedures to go over, and we also, you're also going to see some yard signs that I had made for our staff with our logo on it, announcing the health heroes that we have here on staff that we want to just love on and celebrate a little bit. So hopefully we see those all over town pretty soon, or all over the county. And other than that, I think that's all I have right now, unless there's any questions.
Scott, on FCOA, what do we need to do to get them to that next level?
Press them. Tim's sending them a letter, trying to get a response back out of them. You're talking about FCOA? Did I hear that right?
Yes, sir. Yeah, FCOA.
Yep. Tim's sending them another letter, trying to get them off center to start talking to us. I think it appears they're sitting on their hands, waiting to see how serious we are.
Is that to get them to that point, is it potentially going to require some kind of a suit that force them to answer?
It may, or maybe just the threat of one.
Okay. Well, they seem to be about it.
Yeah, the ball is in their court, and we're just not getting a reply back from them. I do know he needed to get some additional information out of Melody and Jenny. So there may be a little bit of effort left on our part, but we're still not getting much of a response from them, other than we received your communication and we're investigating.
Okay.
On the policies and procedures, I'd like to offer a motion that we accept all of the policies in one motion as a group.
I had a question about the 401k contributions. Is that has that been any other discussion around the contribution? I know it really doesn't have anything to do with the policies, but has there been any other discussions about the match for this year? Or, well, it would be for 19, wouldn't it?
So we've gotten the calculation back. They're in the process of auditing the 401k right now. That'll be completed and should be available when they report on the financial statement audit in August. The calculation for the match for 2019 is about, I don't remember the exact amount, but it's right at $220,000. So we'll need to make that match after the audit's complete around September.
Okay, and you anticipate the audit being completed when?
They're in the process of conducting the audit right now, as well as the financial statement audit, and they should be done with both by the August board meeting. They typically report on the financial statement audit at the August board meeting.
Okay, so you should be bringing that to us by that time, and then we can take official action on it.
Yes,
Correct.
and I can tell you that the match right now, as it should not change, other than the ability to offset some forfeitures possibly, but it's right at $220,000.
Okay. All right. Motion from Carl to accept all the policies and procedures presented in the board packet. Do I hear a second?
I'll second it, Mike.
Okay, motion by Carl, a second by Jay. Any other discussion? All in favor say aye.
Aye.
Any opposed? Motion carries. Obviously, the anesthesia contract's already been dealt with, so I think that pretty much wraps it up. Is there anything else that we need to discuss?
Just one thing, quickly, Melody, can you give them an update on the direct care payments and the indirect care payment grant that we're going after?
Sure. So for the governor announced the direct care worker payments several months ago. There's two different groups. There's the long-term care, which includes our home health staff, which was extended through June 30th. Originally, the ending date was May 30th, and they've extended that through June 30th. And then there's the hospital side that went through May 30th. And so we've submitted all of the required paperwork for all of that. We received funding from the state or from Medicaid for the first 4 weeks of the program. It's an 8-week program. So we received that payment, and we have paid that out to our employees. And we are currently waiting on payment for the remainder for the other 4 weeks. And then we will also submit through June 30th for our home health workers, and they will get their payment as soon as we receive it. So we have done that. And then for all of those who are ineligible under the state program, we have the SHIP COVID grant that we applied for that I haven't received approval on, but I don't anticipate it being an issue. But one of the things that could be included in that program was hazard pay. So we projected to be able to use the $84,000 to provide some incentive compensation, some hazard pay for all of those employees who have been here, who've been working just as hard to keep their departments rolling through all of this, and using that funding to give them a little bit of incentive compensation. Does that answer that, Scott?
Yeah, so
okay.
That's the indirect care payments, that grant you just talked about, excuse me, that would go to people that aren't receiving the state funded direct care payments.
Correct, yes.
Yes, just want to make that clear.
I have just a request for our next board meeting. If it's possible, I would like to see those cash inflows we've had itemized with some bullet points about how we're supposed to spend it or how you can't spend it, just so that we understand the source of the funds and how we get to use them or don't get to use them.
Sure, I can do that. Not a problem.
One thing I overlooked under new business is the renewal of my board term. That's a Judge Aiken thing. He's not on the call today. Stephanie, are you still on the call? So anyway,
Hey, I'm still here. I just ran in here. I don't know what's happened again, but the same thing happened to Robin. She wanted me to ask Melody that the policy that was approved on the 401k, what were the changes from what we had before?
That's a new policy, so there are no changes. That's a completely new policy. We've been remitting employee contributions. We did not have a written formal policy, and so that's one of the things that has come out of the audit, that we need a written policy in how quickly we remit those contributions, and how we do it. And so that's what that is putting that in writing on paper. It's in what we've been doing in practice. We just needed something in writing.
And she just asked, does a policy mandate a contribution?
The only thing that would mandate the contribution is going to be the plan document.
Okay.
Okay, Stephanie, I was talking about the renewal of my term. Of course, I haven't spoken to Judge Aiken about it, but did you say, have you talked to him? Is there anything to do officially?
No, yes, I've talked to him, and he was supposed to get in contact with you just to hear from you that you were up on, continuing to do another 7 years. And then that was it. There was nothing real official.
Well, I don't have anything official to report because he and I haven't spoken. He may be off.
No, he didn't say that.
I'll try to talk to him.
Okay.
Okay. Anything else? Okay. Well, thank everybody for their time. I'd entertain a motion. We adjourn.
So moved.
I'll second it. All in favor, say aye, and we'll see you at the next meeting.
Thanks.
All right. Thank y'all.
Thank you.
Bye-bye.